And I think you hit on all the directions that we're actually intending on developing this study. So the first is we're trying to collate the results of the genetic testing to determine at what rate our patients on a retrospective basis were found to be negative, positive, or possessed variants of uncertain significance. And then depending on that, we're going to basically triage into three categories and see how patients with positive genetic mutations were managed depending on their mutation status and what the literature says, how patients possessing variants of uncertain significance progressed or didn't progress. And then for patients who are negative, we're just trying to see just general follow-up with the urologist and the urology practice to see if there was any attrition rate for these patients. And, obviously all of this is going to take place on a long-term basis. So we're really trying to pare the data down to give us some high-level outcomes, ideally. I mean, it's an arduous process. It's all retrospective. Everything's in the chart, and 3 or 4 different charts, and there's some EMR transitions that occurred. So it's the difficult thing isn't necessarily making sure that you get all the data. The difficult thing is making sure that you're including patients which only possess the highest level of data, and not kind of watering down your data set by including patients with missing values and things of that nature, which is one of the things that we really took pride in with this initial study. So we're trying to maintain that high degree of scrutiny when we're doing this retrospective review. But I mean, it's still in the data collection stages, but nearing the end of that phase.
I can also add to that. Again, this brings together sort of the fragmentation in healthcare a little bit. So when patients progress and they need treatments, they end up seeing an oncologist. So we have to look in the oncology electronic medical record as well. Some patients may go for clinical trials. So we are definitely going to follow up on that data. The other data, which will be interesting, which was going to be a lot more time consuming, we're not going to get into it right now, is did these patients then inform their family members who could be at risk, and what was the rate of testing in those family members? Because you're then talking about one person's genetic testing affecting potentially 10 others. If they had 4 children and 3 siblings, so all the children technically should be tested to see if they carry the mutation, depending on the genetic pattern of inheritance, and the siblings and their offsprings as well. So there is huge potential for this to becoming a cancer diagnosis altering step, almost a paradigm shift. But it's going to take a lot of time, and it's going to take, getting a lot of people involved in the process.